Hello and welcome to sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. I'm your host, Jillian Whiting.
And I'm Dr Maria Boulton, GP specialist and former president of AMA Queensland.
Today, to mark Heart Week, we're talking about one of the most important and preventable health challenges facing Australians today, cardiovascular disease.
And importantly, what this means for clinicians on the front line, recognising risk, knowing when to escalate, and understanding the rapidly evolving treatment landscape.
Joining us is Dr Nick Aroney, a Queensland-born, bred and educated interventional and structural cardiologist.
Nick's clinical interest and expertise in the management of aortic stenosis, acute coronary syndromes, structural heart disease, cardiac 3D modelling, and risk factor modification.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Nick, welcome to sMater.
Thank you for having me.
Let's start with you, a little bit about you. Can you tell us about your work and what you see every day working as a cardiologist in Queensland?
Yeah, thanks. So I think first and foremost, I'm a general cardiologist. So I spend a lot of my day seeing patients in clinic and seeing patients on the ward. And those are patients that are coming in with symptoms of heart disease, chest pain, breathlessness, and we're organising investigations and trying to get to the bottom of it. And the other part of that is seeing patients that have risk factors for heart disease. And we're trying to see what we can do in terms of lower their risk of developing heart disease long term. And so that's one of my hats. And my other hat is that of an interventional cardiologist. So that's where I work in a cardiac catheterization laboratory, procedure room or an operating room. And I do minimally invasive techniques, so essentially keyhole procedures, treating heart disease, putting in stents and replacing valves that way. So that's my day-to-day.
Nick, as a GP, sometimes it's challenging to know what cardiologist to refer patients to, but as a general cardiologist, you accept anyone?
Yeah, so definitely in clinic, I see all comers. So I deal with risk factor modification and patients with high blood pressure and high cholesterol. But I think my specialty area is very much treating patients with coronary artery disease, so patients with chest pain, patients that have blocked heart arteries needing considerations of stents or bypass surgery, and patients with valvular heart disease. So generally that's the older population, which are breathless, and they have a problem with their heart valves or a heart murmur, and see those patients and determine whether or not they need treatment with medications or more, such as procedures.
And what drew you to the interventional cardiology side?
Yeah, so interventional cardiology, I found it was quite satisfying. You could see a patient, such as a patient coming with a heart attack in hospital who's very unwell, and you could essentially take them to the cardiac catheterization lab, find out where the artery is blocked, unblock the artery, patient's well sort of 20 minutes later and leaving the hospital the next day. So I think it was the combination of imaging and procedural skills and the sort of seeing the tangible benefit to the patient pretty immediately afterwards.
And it's incredible. I mean, I remember my grandparents all died in their 50s from heart disease. And nowadays, I believe they would still be alive had they had, the modern care that we provide today, right?
Yeah, and talk to a lot of my patients. That's very touches home with a lot of them. You hear about their family histories, and a lot of the grandparents started developing heart disease in their 50s, 60s and 70s, and there just wasn't really the technology or treatments then to really sort of make a big difference, unfortunately, but that has changed a lot.
Just on that, are patients presenting earlier or when they should, or are they still coming a little bit later?
So there's probably two groups. There's the very motivated patients that are very aware of the risk factors, and they're coming in early, having had discussions with their GPs about elevated cholesterol, high blood pressure, and they essentially want to be doing everything they can to improve their longevity. So we are seeing those patients, and that's fantastic that those messages have got out there. But unfortunately, there is still the sort of the classic patient of the bloke that's basically put up with chest pain for, weeks and weeks and weeks and attributed it to reflux or musculoskeletal pain, and they come in quite a bad way often. So we're still seeing both of those populations.
Which is what Heart Week's about as well, is getting those messages out. What about proportion of women coming to see you when they should?
Yeah, so we definitely see the proportion of women who are motivated to get on top of their risk factors, as I said in the first group. But unfortunately, with women, the classic symptoms such as central chest pain radiating into the arm, we know that doesn't when it's not seen essentially in women as classically it is in men. So women, essentially the symptoms can be a lot more atypical. So it can be sharp, brief chest pains or pains elsewhere in the chest, which again can be confused with other pathologies. And because of that, these patients can get missed.
It's really interesting. My patients sometimes attribute a heart attack to heat stroke and present quite late, and then you find out that they've actually had MIs rather than heat strokes. But I think with women too, I think women in their minds, they have the idea that perhaps the main cause of death for women is breast cancer or ovarian cancer, when in fact it is heart disease. And they're so busy caring for everybody else that they don't come and get that preventive care that sometimes men get.
Cardiovascular disease remains the leading cause of mortality in Australia, accounting for around 1 in 4 deaths, or a death every 12 minutes. More than 4.5 million Australians are currently living with cardiovascular disease, with the majority managed longitudinally in primary care, placing general practice at the centre of both risk modification and early detection.
As a GP, when we have a patient with coronary artery disease, ideally what investigations should we be doing on the way to see you?
Yeah, so pre-referral for patients with, suspected coronary artery disease, whether or not they have chest pain, is an important sort of discriminator. But these patients essentially should all come in with up-to-date bloods, including lipids, which include an LDL. Ideally, some blood pressures from yourself or from their home. The blood pressures generally, when they come see me in the office, are always a little bit elevated. The HbA1c, smoking, medication history, and in addition to that, very much a CT coronary calcium score I find is very useful. So the CT coronary calcium score, in addition to the traditional investigations, just allows us to personalise and individualise treatment. So the risk calculators are great on a population level. I'm working out who is low, intermediate and high risk, whereas we know traditionally that they can actually either over or underestimate patients. So I see some patients even in their 40s with none of the traditional risk factors. So they're not smoking, they don't have high cholesterol, they don't have type 2 diabetes, but maybe they had a family member that died in their 50s of heart disease. And I see those patients occasionally have a CT calcium score and it's elevated. And so it lets us then detect those otherwise who would have been classified as low-risk patients, start treatments early in them and make a sort of a long-term difference with those patients. And in addition to sort of reclassifying those low patients into high-risk patients, the same goes, I occasionally, not that commonly, but I occasionally see the 40, 50-year-old patient who is smoking and does have high cholesterol, and they've got a calcium score of 0, which means they actually have a low risk of heart disease and heart attack in the next 10 years. And it makes it a little bit tricky with our population as to whether or not you start statins earlier, but you can have an informed discussion with them and maybe focus on some of their other risks such as smoking cessation. So it does cut both ways, but it allows you to individualise your approach.
Are you still finding that some patients push back on the statins?
Yes, I think broadly statins probably got a little bit of a bad name sort of decades ago when they were overprescribed and we didn't have testing such as CT calcium scoring to basically individualise who actually has the disease, because that's what the calcium score does. It says, do I have atherosclerosis? do I have coronary artery disease? And it's those patients we know, particularly when the scores are quite high, above 100, that they benefit tremendously from treatment with statins. So the high-risk patients, so the patients with scores over 300 and 400, those patients essentially have the same risk of heart attack as someone that's already had a heart attack. So those patients need to be treated very aggressively. And I think once you lay it out for the patient, you sort of show them their calcium score. If you've got the imaging, you can show them the imaging. I don't find it's a very hard conversation to start those patients on medications which make a real difference.
And what about soft plaques? We see them a lot as incidental findings when we're, say, for example, doing a CT chest for mining medicals, for example. Are you as aggressive with if you see soft plaques as if you have a high CT calcium score?
Yeah, so the tricky thing with soft plaque is, I guess, there's no sort of good long-term randomised data for those patients. So they, luckily this is very rare. So patients essentially that have calcium scores of 0 that do still have a heart attack. And it's only a sort of 2-3% of those patients over the next decade. So it's a very rare occurrence, but unfortunately all interventional cardiologists have seen a patient come in with a myocardial infarction who's had a calcium score of 0. And with those patients, again, it's probably just a frank discussion with them basically saying, listen, your calcium score is 0, but we've identified some soft plaque which has, some propensity to rupture. And, whether or not you start a statin with them, I guess, is going to be guided by risk factors, side effects. But a lot of patients are still happy to start.
Nick, how much heart disease can realistically be prevented, and what risk factors do you think people really still underestimate?
Yeah, so we know that if we get on top of cardiac risk factors, that prevention is the best treatment for these patients. So waiting until these patients start to develop symptoms is definitely the wrong thing to do. So if we can detect the disease early, if they have multiple cardiac risk factors and we aggressively treat these, then often we can, prevent most of these patients, 60-70% of these patients from developing meaningful cardiovascular disease long term. What
sort of, spike or interest do you see? So often you'll hear someone in the community or someone has suffered a heart attack or a heart condition, or someone famous like Shane Warne. Yeah. Do you see that? Do you see a big influx, and what impact does that have? Yeah, so all the time, whether or not it's someone in the community such as Shane Warne, or whether or not it's a brother that's had a heart attack or a friend, unfortunately, that's passed away, then we see patients coming in basically trying to see what their risk is. And, unfortunately, it starts off with a tragedy, but I've seen a lot of good come of it, and a lot of sort of subclinical disease detected and treated early. So I think although it does start with a tragedy, I think there is a lot of sort of positive benefits that comes from those events raising awareness.
Each year in Australia, there are over 57,000 acute coronary events, equating to more than 150 presentations per day. Importantly, a significant proportion of these events are attributable to modifiable risk factors, reinforcing the role of general practice in risk stratification, optimisation of medical therapy, and timely escalation where clinical concern persists.
Can we perhaps focus a little bit on treatment? And we just discussed how treatment has changed since my grandparents' generation, particularly when it comes to all the interventions, the PCI, stent, cabbages. Where is treatment now, and where do you see it heading in the future?
Yeah, so patients who don't have symptoms, asymptomatic patients, it's risk factor modification. So high-risk patients targeting LDLs of less than 1.8, blood pressure systolic of less than 135, making sure they're not smoking, they're eating a well-balanced Mediterranean-style diet, and I guess keeping these patients active and avoiding obesity. When patients develop symptoms, that's where tests such as CT coronary angiograms are useful to rule out significant coronary artery disease. Stress echoes are useful in detecting inducible ischemia. And in patients that do have considerable underlying coronary disease, that's where coronary angiograms, procedures I do, where we invasively go up from a little keyhole procedure from the wrist and take pictures of the arteries and find these blockages and treat them with balloons and stents. They can make significant improvement in patients with heart attacks in terms of survival, as well as improving their symptoms. In patients that have complex disease, these patients benefit from coronary artery bypass grafting. And so these are still the mainstay in treatments. There has been some improvement over the last decades in terms of the technology we use, which makes it, I guess, quicker and less invasive, and we don't leave as much behind, essentially. The stents are becoming smaller. There's drug-coated balloons now, so sometimes we don't even have to leave stents in. On that, the stents now aren't requiring as much long-term antiplatelet therapy. So a lot of the stents now we can get away with 3, even in some cases 1 month of dual antiplatelet therapies, and they just go on their aspirin or a single antiplatelet afterwards.
Really changing the game, and recovery much quicker, easier.
Yeah, absolutely. Yeah, patients like it. Most of the time they're home the next day.
Wow. And the other question I had was, when should we as GPs pick up the phone and ask for someone to be fitted in? And bearing in mind that some of our listeners don't live metro. I used to live in Mackay, and at the time we didn't have a cardiologist, in an area of 250,000 people. So perhaps thinking about also those regional and rural GPs, when should they be getting their patients seen?
Yeah. So in terms of triaging, symptoms is king. So although there is a somewhat knee-jerk reaction when you see the calcium score of 1,000 to think that person's going to die the next day, the reality is that it is still stable coronary artery disease, and the treatment for that person is still just aspirin if the calcium score is over 100 plus statin therapy, and then they can see a cardiologist, in a few months' time. That is still very safe. But if someone's coming to see you and they're getting worsening chest pain at rest, if they've got signs or symptoms of heart failure or atrial fibrillation, which is uncontrolled, these are the patients that need to be seen soon, and have your friend cardiologist on speed dial.
And Mackay does have cardiologists now. So.
Yeah, very, very good ones.
That's really good.
I did a cardiology term in Mackay.
Did you?
Yeah.
In the new hospital?
Yeah, in the new hospital.
I was in the old hospital.
Okay, right.
That was a very, very long time ago. So can we focus a little bit on valves, heart valves? And we order a lot of echoes, and we hear a lot of murmurs. When should we start thinking about referring that patient, and what makes it an urgent referral versus non-urgent referral?
Yep. So yes, heart valve disease is definitely one of my passions. So I think the heart valve patient can be tricky because the patient won't come to you saying, I have heart valve disease, this is the problem. The stereotypical patient with significant heart valve disease, the sort of 70, 80-year-old, they'll come to you and basically just say, listen, doc, I'm a little bit breathless. I don't have as much energy as I did 6, 12 months ago. And a lot of them, unfortunately, won't even come with those symptoms because they just attribute that to getting old. And this is because heart valve disease, it's quite insidious. It usually progresses over years and years, and patients adapt to it. So for a lot of patients, basically, once you start getting over 70, 75, I implore GPs to do the heart health check, which includes stethoscope on the chest. And I see time and time again, unless the stethoscope goes on the chest, a murmur's not detected, then an echocardiogram's not ordered, and these patients can get missed. So if someone has a echocardiogram after a murmur's detected and there's any moderate valvular lesion or severe valvular lesion, particularly if the patient does have symptoms, those patients all need to be referred on. So severe valvular heart lesions or moderate heart valvular lesions if the patients have symptoms. Unfortunately, there is some variability in echocardiogram reporting, and so I commonly see patients who come to see me with breathlessness and their echocardiogram says moderate aortic stenosis, and then we redo the test and it is severe. So just have suspicion that if you think your patient has symptoms, they should be seen.
And treatment from that perspective. So can you outline what you're looking at and the processes from there?
Yeah, so treatments of valvular heart disease over the last decades have changed significantly. In the 90s and early 2000s, essentially the only treatments for severe aortic stenosis or severe mitral regurgitation were open heart procedures with cardiothoracic surgeons. And unfortunately, because of this and the recovery involved, that excluded a lot of the population. So the 80-plus-year-olds with comorbidities that thought we're not going to be able to get through an open heart procedure were often just treated conservatively. And treatment of severe aortic stenosis treated conservatively to 2-year mortality. 50% of patients die at the 2-year mark, which is worse than basically most metastatic cancers. So thankfully, over the last decade, we've had a lot of advancements in keyhole technologies, and that's one of the procedures I do. So the specific one to discuss, I guess, is TAVI, so transcatheter aortic valve implantation. And that's treatment for patients with severe aortic stenosis with symptoms. And these patients essentially come into hospital. We look at their heart with CT scans and measure their heart valve and their legs. And we plan a procedure where we put a little tube up from the leg across the valve, and we put a new valve in place and open it up with a balloon. And it takes about 20, 30 minutes, that procedure. Patient's up at about the next day, and they're feeling a lot better the next day, and you're dramatically changing those patients' survival. So, and that procedure's gone from the last 2 decades from sort of only treating high-risk patients, so the sort of 80, 90-year-olds. Now I'm having 60-year-olds come to me with aortic stenosis, and they want to get back to their work the next day or their golf game on the weekend, and they want to avoid open heart procedures, and they're asking for TAVI. And those patients it's a bit more of a discussion about what's going to be best for them long term. But a lot of them can still have TAVI procedure.
So with the older patients, so the 80, 90-year-olds, it's well tolerated?
Yeah, so the procedure now, patients awake. It's just performed in a standard cath lab. They get some light sedation, and it's just a keyhole procedure from the groin. And usually, as I said, 20, 30-minute procedure. They're lying down, groin recovery for about 3-4 hours afterwards and up later in the day. There are some risks involved. There's a 5% risk of a pacemaker afterwards, which is similar to if they undergo surgery, but no, very, very well tolerated procedure.
So many changes over the last decade in particular, as you're mentioning. What about other technology, imaging, 3D modelling? How are they changing outcomes and recovery times and the work you do?
Yeah, so Mater Hospital's just recently installed 2 new state-of-the-art cath labs, and one of which has a 3D mapping lab. And so this is used to treat patients with electrical heart problems or atrial fibrillation. And so atrial fibrillation, as you know, in your busy practice is very common, and there's escalating ways of treating it. So we treat it with medicines to slow it down, medicines to get them back to normal rhythm. But more and more commonly now, the guidelines are telling us that patients like to be in sinus rhythm, normal rhythm long term. And the ablation procedures have become a lot safer with improvement technology such as the mapping systems, as well as the pulse field catheters, which are new in the last few years. And so we're starting to perform these now at the Mater Hospital in the next coming weeks. So that's going to be very exciting for us.
So as GPs, we look after patients all ages, and sometimes we're at a loss as to where to refer patients who had heart disease as children. Does Mater look after them?
Yeah, so given our proximity with the kids' hospital next door, we're lucky enough to have a number of cardiologists that specialise just in adult congenital heart disease. So that's basically adults that were born with heart problems, which were either treated at the time or have been under monitoring, and now those heart problems are starting to cause issues as they're becoming adults. And so we've got the Mater Adult Congenital Heart Unit here, and we have regular meetings with all our cardiologists to basically find the best treatments for these patients. And
that's quite a specific field, and patients do better under that care.
Yeah, well, we find a lot of the time that other cardiologists aren't comfortable looking after these patients. And the team we've got here, they're all Australian renowned, well-trained experts. So we're very lucky to have them on board.
Looking to the future, Nick, is there anything particular that you're excited about, research-wise, or the work that's happening here at MATER?
Yeah, so one of the other sort of niche treatments we offer here at the MATER Hospital, which I'm very excited about, we've started our a heart-brain team. So that's a team of cardiologists, radiologists, and neurologists. And we're treating young patients that come in with stroke. And so when young people come in with stroke, we don't look just at the conventional causes of stroke, which are AF and atherosclerotic disease in the head and neck. We look at patients that essentially have small holes in the heart, PFOs, and we look at whether or not these need to be closed with transcatheter techniques. And again, we have regular meetings with our neurologists, very good relationships with them and our radiologists, and come up with the best treatments for these patients.
And what's the recovery time?
So these patients get investigated, come into hospital, and when it's determined that we need to do a PFO closure on these patients to reduce their long-term risk, the procedure again, 20, 30-minute procedure, usually up and about the next day. So quite good.
That's great news.
I have one last question because I'm a GP. We all do quality improvement programs at our practices. What is the one thing we could focus on for a quarter that would make the biggest difference when it comes to the prevention of heart disease in our patients?
As in auditing or yourselves?
Yeah, as in something we could, for example, in coming to winter, we're focusing on making sure that everyone has a flu vaccine, particularly those high-risk patients. So should we focus on reducing smoking, on checking their cholesterol, their blood pressure? What's the one thing that can make the biggest difference?
Yeah, I think I'd probably go back to what I mentioned earlier. The two groups of patients that I think should be screened is the younger patients, whether or not they need a CT calcium score to determine whether or not they do or don't need to be aggressively treated, and then the patients over 70 to make sure that they've had a heart health check at some point in the past years, including auscultation of their heart. I think those are the two main points I would make. I mean, as I said, the amount of patients I see that have seen doctors, including cardiologists in the past, and clearly no one's put the stethoscope on their chest. And unless the stethoscope goes on, these diseases sort of go missed.
And wouldn't it be great to get rebates for the CT calcium scores?
Yeah.
Because the cost can be prohibitive for some.
Yeah, no, it is a bit of a shame. I mean, I'd sort of hope that at some point the government does come around on that, because I think probably the disease long term that it prevents would well and truly cover the sort of smallish upfront costs.
Well, maybe somebody is listening to this podcast, so good luck with that. Anyway, Nick, thanks so much for joining us here on sMater, particularly to mark Heart Week, for what's been a really practical and very insightful discussion.
Pleasure. Thanks, Jillian. Thanks, Maria.
For our GP listeners, we hope this helps in those everyday decisions, when to reassure and when to escalate.
This podcast was brought to you today from Meanjin, the land on which it was recorded.
For our listeners at home or in the car, or having a well-deserved break between patients, thank you for tuning in.
See you next time on sMater.